Address of RowanSOM's second annual Diversity Week. Now, before we begin Dr. Levine's talk, I do have a little bit of bad news. She did get called into a meeting with the Pennsylvania governor. She is Physician General of the state of Pennsylvania. And because Harrisburg is 4 hours away, she was unable to make it to give this talk in person. However, she did pre-record this lecture, and we will have her on the phone for a live Q&A session after the talk is over, around 12:35, 12:40. So that said, I'm going to give it over to Dr. Chanel to introduce Dr. Levine's talk.
You should always feel free to clap for me. Okay, so good afternoon. I just want to encourage everyone, even though this is a pre-recorded lecture, to please still respect the tone of the room so that everyone can hear the lecture, and that Dr. Levine will be available live after the pre-recorded lecture is over. Dr. Rachel Levine is currently the Physician General for the Commonwealth of Pennsylvania and Professor of Pediatrics and Psychiatry at the Penn State College of Medicine. Dr. Levine graduated from Harvard College and the Tulane University School of Medicine. She completed her training in pediatrics and adolescent medicine at the Mount Sinai Medical Center in New York City. She joined the staff at Penn State Hershey Medical Center in 1993, where she started the Penn State Hershey Eating Disorders Program. This program offers multidisciplinary treatment of children, adolescents, and adults with eating disorders such as anorexia nervosa and bulimia nervosa. Please welcome Dr. Levine.
Good afternoon. I'm Rachel Levine, and I'm the Physician General for the Commonwealth of Pennsylvania. I am so sorry that I'm not able to be there in person, but hopefully this is the next best thing. So I was really so pleased to be invited to be your keynote speaker for Diversity Week, and invited by the Action Council for Inclusion, Diversity, and Equity from the Rowan University School of Osteopathic Medicine. So we're going to talk today about health issues and LGBTQ issues. So the first thing I like to do is to establish some terms. And so you're probably familiar with, or maybe not familiar with, the alphabet soup in terms of the LGBT community. So if I say LGBT, people know that I mean lesbian, gay, bisexual, and transgender. But if I say LGBTQIAAP, etc., then people kind of get lost in the letters, in the alphabet soup. So let's go through that. The LGBT does mean lesbian, gay, bisexual, and transgender. The first Q would be questioning. So that would be those individuals who might question their gender identity and expression or their sexual orientation. Might be youth or other people who question that. The second Q is queer. Now, when I say queer, people my age kind of shudder, because queer was a very negative, derogatory term in the past. But queer has been taken over by the community, especially among youth, as sort of an umbrella term for the whole community. So many people, especially young people, will proudly announce that they're queer, which means that they're part of our rainbow family, so to speak. Intersex means those who are medically intersex. The current term in medicine is a DSD, or a disorder of sexual development or disorder of sexual differentiation. So those are individuals who have a medical condition. It could be genetic, chromosomal, or an endocrine condition, which lead them to an intersex state, and sometimes require medical intervention at times. The first A is asexual, or agender, those who don't declare a sexual orientation or a gender. And the next A are allies. And allies are critically important to our community. Though the allies are individuals who are not LGBTQ, etc., but support the community. Absolutely critically important. P sometimes is pansexual or pangender or polysexual in terms of how they identify, and the terms continue. I want to distinguish three terms or phrases which I think is very important. The first is gender roles, sexual orientation, and gender identity and expression. So gender roles are how you might function in your family, in your community, and in society, traditionally on a male or female spectrum. And the best example I have of changing gender roles in the last 50 to 75 years is my very dear 92-year-old mother. My mother was the only graduating female law student at Boston University in 1946. At that time, women really didn't enter professions such as law or medicine or business. Now, of course, 50% of almost any professional school class will be female. Your sexual orientation is how you identify in terms of who you're attracted to, who you might want to have a relationship with, who you might want to be intimate with. Your gender identity and expression is how you feel inside and how you want to express that to society and your community, traditionally male or female. It's important to emphasize that there is no particular overlap between sexual orientation and gender identity. So, for instance, you might have someone who is male to female transgender, has a transgender girl or a woman who is attracted to men or women or both or neither. You might have a female to male transgender boy or transgender man who is attracted to men or women or both or neither. So there is no particular overlap in terms of those terms and expressions. So sex is the physical expression of your genes. Gender is, as I mentioned, this self-perception of how one relates, of yourself and how one relates to society. Traditionally, masculine or feminine, male or female. A hypothesis I'd like to put forward is that the organic basis of gender identity is a reflection of neurodevelopment of the brain. So that's in contrast to previous hypotheses, is that it was somehow had to do with your upbringing, especially at a young age. Now, to be fair, there are still individuals who do follow that, tend to be more developmental psychiatrists or psychologists, rather Freudian in their orientation, but that isn't the prevailing theory in the medical community. So let's look at some data that we might be able to demonstrate for my hypothesis. There are some older studies, sex difference in the human brain and its relationship to transsexuality. Male to female transsexuals have female neuron numbers in the limbic nucleus. So the idea is that men and women have somewhat different brains. Of course, there's tremendous overlap, but that certain structures of the brain might be a different size or shape or neuron number, depending upon whether someone is male or female. So the idea is that, and from these studies, that transgender women's brains, male to female, looked rather female, and transgender men's brains, female to male, looked rather male. This was a larger study, sex difference in the hypothalamic uncinate nucleus in relationship to gender identity. So again, there were differences in this nucleus in the hypothalamus, and for transgender women it looked more female in size and shape, and for transgender men it looked more male in size or shape. One of the biggest problems, however, with these studies is that, and a big variable, was that they were done after the individuals had hormones. And so you can't tell if this is the effect of the hormones or if this predates the hormones. So the future is going to be in structural and functional neuroimaging. So these are studies done often before and then after hormones. So this study looked at something called white matter microstructure with a diffusion tensor imaging protocol. And it showed that in the white matter microstructure in untreated transgender men looked rather male. And the companion study, the white matter microstructure in transgender women, looked in between male and female controls. This was a gray matter study, and again, transsexual subjects didn't differ significantly from the controls that shared their gender identity. Now, if you look at more functional neuroimaging, looking at how the hypothalamus might activate with different odorous steroids, again, the same pattern that we see is that in transgender women, the function looked rather female, and in transgender men, or children, it looked rather male, and these were before hormones. So in summary, these quotations, gender identity, whether consistent or inconsistent with other characteristics, say birth sex, is not a matter of choice, it's a matter of biology. And the scientific evidence supports the paradigm that transsexualism is associated with neurodevelopment of the brain. In other words, it's basically just the way you are. In terms of transgender medicine, the diagnosis is now called gender dysphoria in the DSM. As you know, the DSM is the Diagnostic and Statistical Manual of Mental Disorders. Say that 3 times real fast, it's kind of hard. So in DSM-5, published in 2013, the diagnosis is gender dysphoria. And this is a revision from DSM-4 when it was called gender identity disorder. The idea is that being transgender is itself not necessarily a disorder. And it's defined as the difference between their experienced or expressed gender and the gender essentially that they were assigned at birth. And that needs to continue for at least 6 months. In children, it's the desire to be the other gender which is present and verbalized, and that in general that it causes some clinically significant distress or impairment, and there is a post-transition modifier for those who have fully transitioned. Now, I personally think that in DSM-6, when young people might, as yourselves, might be writing it, is that gender being transgender will come out of the DSM. You have to remember that until the mid-1970s, being gay, lesbian, or bisexual was a mental disorder in the old DSM. So I think that it'll come out and be different in terms of how it's diagnosed. The standard of care for transgender medicine is established by an organization called WPATH, and that's the World Professional Association for Transgender Health. Used to be called the Harry Benjamin Organization after a famous sexologist, Dr. Harry Benjamin, in New York in the 40s, 50s, 60s, who treated actually Christine Jorgensen, who transitioned in the 50s. The last revision was in 2011, and there is a new revision pending. And it really describes this and pronounces the standard of care for the evaluation and treatment of transgender patients. It includes a psychological evaluation and treatment. There can be medical, hormonal evaluation and treatment, and then possibly surgical evaluation and treatment. So the WPATH standards of care describe what is the eligibility criteria for hormone gender reassignment, for hormone replacement therapy. And those standards are that the individual must demonstrate knowledge of what hormones can do and what they cannot do. A mental health evaluation is still a requirement for hormone therapy, somewhat controversial. If someone needs hormone therapy for menopause, they don't need a mental health evaluation. If a genetic male in his 50s or more wants testosterone, topical testosterone, they don't need a mental health evaluation, but it's still recommended, at least in this revision, for hormone replacement therapy for gender transition. A period of psychotherapy is recommended but not required. Now, I'm a big fan of psychotherapy and psychological support. I think it is challenging to change one's gender, but I think it's valuable to have psychotherapy, but it's not a requirement. It does recommend these criteria that an individual live as the other gender for 12 months before genital surgery, and there are age considerations. Now, in the new WPATH standards, then probably will be some adjustment for what I call gender non-binary or gender non-conforming individuals. So, all the different definitions we were talking about before did assume this binary of male or female, but there are many individuals, particularly young people, who do not accept that binary. A great conference to go to is the Mazzoni Center Trans Health Conference. It'll be given next year in September in Philadelphia, and you'll see hundreds of gender non-conforming, gender non-binary, genderqueer youth who do not accept whatever definition of gender we might have. So the guidelines still have to catch up with that. So why would we give hormone therapy? Cross-sex hormonal treatments play a very important role in the anatomical and psychological gender transition process. Hormones are often medically necessary to live in the new gender, and they certainly have been shown in many studies to improve the quality of life and limit psychiatric comorbidity which accompanies lack of treatment. So for treatment, as I was mentioning before, there's psychological treatment, medical treatment, and surgical treatment. And it's important to understand that not all patients want surgery. Now, there are lots of reasons for that, which we'll go over. So for hormone replacement therapy, there are male to female regimens, including anti-androgens to block the action and production of testosterone, and estrogens. And then female to male regimens with androgens, primarily testosterone, and there are benefits and side effects. But essentially what you're going to be doing is placing the individual through puberty. So, puberty takes several years, and so people have to be patient with the pubertal changes that occur. So this is the medical article which establishes the medical procedures for gender transition. It's published in the Journal of Clinical Endocrinology and Metabolism in 2009, and it establishes the guidelines for the medical evaluation hormone treatment for transgender adolescents and adults. And it's accepted by the important organizations that govern that care. So for anti-androgens, this blocks the production and effect of testosterone, and you have to block testosterone for the estrogen to work. Primarily, we use a medicine called spironolactone, which many of you might be familiar with is also a potassium-sparing diuretic, and we're using it for this other action of blocking the production and action of testosterone. And then you're going to give estrogen in various forms, oral estrogen or topical estrogen, in some cases intramuscular estrogen. This will cause changes in the skin. The skin will become finer and softer. Female fat distribution from the abdomen to breasts and hips. Loss of about 20 to 25 up to 30% of muscle mass. Breast development usually maximizes in 2 to 3 years. Decreased hair loss, decreased body hair. Improvement in mood. Patients, when they get the hormones consistent with their gender identity, consistently report an improvement in mood, and heightened sensitivity to smell and color. Side effects, it can cause breast tenderness. Essentially, again, they're going through a girl's puberty. They might have a breast bud, might be a little tender, asymmetrical. We do watch prolactin levels. High blood pressure could occur, although usually you're on spironolactone and it doesn't. Breast cancer would be reportable. The biggest risk factor which we're watching for are thromboembolic effects, so a blood clot. And firstly, in the first year of treatment, or if you significantly change the preparation or the dose. And we really want patients not to smoke. Thromboembolism would be rare, but it's something to consider. And then decreased libido and loss of erections. So you might think that an individual would not want to use their penis in sex if they're a transgender woman, but maybe they do. And so you need to don't make those assumptions and ask the patient about what they're looking for in terms of their sexual function, and you can adjust doses accordingly. For transgender men, we use primarily testosterone, but you can't use oral testosterone. So it's usually given as an injection, and there is topical forms that could be used as well. Again, now you're going to go through a male puberty. So first changes are cracking and deepening of the voice, which occurs over a number of months. Periods cease within a number of months. Muscle mass increases, especially if the person works out. Reduced fat distribution and redistribution of adipose tissue to the male pattern. Facial hair can develop. You can have male pattern balding. Acne can develop. And the clitoris enlarges, but it, of course, doesn't become a functional penis. Now, remember puberty? The audience usually laughs when I say that. Well, the issue is puberty is difficult for all of us. But what if you're going through the wrong puberty? What if you are a male to female transgender teen, a transgender young woman, and now your voice drops, you get facial hair, body hair, your muscles are enlarging? What if you're a transgender young man and now you have breasts and periods? this can be quite difficult, and a lot of depression and sometimes even suicidal thought during this time. So the previous standard of care was see you when you're 18. I'm really sorry. But there are new standards of care that have been developed. Now, it recommends no medical treatment for prepubertal children. Well, that makes sense. They're prepubertal, so they don't have clinical levels of sex steroids. But right at the beginning of puberty, at Tanner stage or pubertal stage 2, right at the beginning of puberty, if they fulfill all the criteria, no serious psychiatric comorbidity, and they have adequate support, you can do this new protocol. Now, this protocol was developed in the Netherlands, but is now widely used in the United States. And it conducts hormonal treatment in 2 stages. So right in that peripubertal period, so we're talking about maybe 11 or 12 for genetic natal women, or maybe a little older for genetic men, you're going to use a pubertal blocker. So you're going to give a medicine to block puberty. That's a gonadotropin-releasing hormone agonist. Might be used for precocious puberty in other patients. So you're going to block puberty for several years, and then somewhere between 14 and 16, if the therapist, the family, the doctor, patient, of course, is on board, you can start to put them through the puberty consistent with their gender identity over a period of number of years. In the Netherlands, it's at age 16 because that's the age of majority. In the United States, usually somewhere between 14 and 16. There are follow-up protocols established, and usually surgery would be at 18, maybe slightly below 18. A word about surgery. The current term is gender confirmation surgery. There are male to female regimens, female to male regimens, facial feminization surgery, but don't assume all patients want surgery. Now, as I'll mention in a minute, we're doing a better job covering surgery with insurance, but it does involve, it's big time surgery. It involves days in the hospital, weeks out of work, and not everybody wants surgery. But there are very expert surgical procedures. Challenges in transgender medicine in the future. Creating access for treatment. So we need better training programs for the psychologists, the medical professionals, and the surgical professionals in terms of these principles of transgender medicine. We also, as I mentioned, need newer treatment guidelines for gender non-binary individuals. And we need to work on reproductive options. So it isn't particularly good for viability of sperm for a transgender woman to be taking spironolactone and estrogen. It's not very good for viability of eggs for the individual transgender man to be taking testosterone. So we need to have better reproductive options. A transgender woman can bank sperm. For a transgender man, you can bank eggs or fertilized ovum, but that's very expensive. So we need to work on fertility preservation. I'm going to switch gears a little bit to finish up discussing LGBT health disparities. LGBT youth are 2 to 3 times more likely to attempt suicide. Lesbians are less likely to get preventative services for cancer, particularly reproductive cancers, so cervical cancer, ovarian cancer, breast cancer. Gay men still represent 2/3 of new HIV infections. And a startling statistic from the CDC this year is that 50% of men who have sex with men of color will have a prevalence of HIV in their lifetime. 50%. Startling statistic. Lesbians and bisexual women are more likely to be overweight or obese. And the LGBT population does have higher rates of tobacco, alcohol, and other drug use. In fact, we're targeted by tobacco companies for tobacco use. Transgender individuals face particular disparities. Up to 28% of transgender women test positive for HIV. I was asked at a lecture last week why that was so. Is unfortunately transgender individuals have very poor employment options and have a hard time getting jobs, and sometimes will do sex work for money, and which puts them, of course, at risk for HIV. Victimization. At the same time that we've made progress in the LGBT, in particular the transgender community, in 2015, 21% of transgender individuals, 21 transgender individuals were murdered in 2015. And in 2016 so far, that's 19 individuals. 41% of transgender individuals have had a suicide attempt. 41%. Transgender individuals are less likely to have health insurance. And now, with regressive bills such as House Bill 2 in North Carolina, which requires, for instance, high school students or middle school students to use the bathroom of their birth certificate and not consistent with their gender identity, kids will not go to the bathroom and are at risk of having urinary tract infections. Now, for LGBT youth, there are developmental challenges that we all face in adolescence: independence from one's parents, and developing more independence and more adherence to peer groups, etc. Well, LGBT youth have the same developmental challenges as other adolescents, but they have some other challenges. One, establishing a comfortable sense of their sexual orientation or their gender identity. Dealing with internal or external homo, bi, or transphobia. Receiving limited support sometimes from family, peers, other adults, coaches, teachers, etc. And sometimes having limited contact with other LGBTQ youth or role models. Yet, despite these challenges, LGBTQ youth show remarkable resilience to the challenges that life presents. They are at risk for negative health outcomes in terms of substance use, depression, anxiety, and suicide attempts, but there's nothing inherent in terms of sexual orientation or gender identity that predisposes them towards those negative health outcomes. It's the victimization, the harassment, the bullying that LGBTQ youth face which predicts these outcomes. And unfortunately, too many sexual and gender minority youth and adults have experienced verbal, physical victimization based upon their sexual orientation or their gender identity. Data from the National Crime Victimization Survey estimates that there are almost 37,000 or more hate crime victimizations annually against LGBT people. 2 times more likely not to go to school because they felt unsafe, and higher rates of physical and sexual harassment and violence in schools. According to Healthy People 2020, it's these social determinants of health that affect the health outcomes of LGBT individuals, and they are related to the oppression, discrimination, and victimization that we face. And that might be legal discrimination in terms of employment, adoption, retirement, and housing. Lack of laws protecting against bullying in schools, and lack of social programs for LGBT youth, adults, and elders. Barriers to accessing health care include stigma, outright refusal of care, or inadequate care because of their LGBTQ status. Lack of provider knowledge and training, lack of health insurance, and fear of talking with a doctor about sexuality or sexual health or other issues, fear of coming out to their doctor. So to deal with these issues in Pennsylvania, under Governor Wolf's leadership, Governor Wolf is a strong supporter of the LGBT community. We have formed an LGBTQ work group with the Governor's Policy Office, and I am pleased to chair that group with the Governor's Policy Office. And this includes the Department of Health, Human Services, Department of Insurance, Office of Administration, Department of Corrections, the Pennsylvania State Police, and other programs where we're working with community stakeholders such as Equality PA, Transcendental PA, and the PA Youth Congress on all of these issues. And you can see us there. So some successes of the work group are changing the operational policy at the Department of Health for transgender people to change the gender on their birth certificate. Pennsylvania Medicaid now covers gender confirmation treatment, although we still have issues with access. And we're working with the Pennsylvania Department of Education on issues for transgender students and athletes under the new Title IX guidance to schools from the Federal Department of Education. We're also working with the Pennsylvania Department of Corrections in terms of its PREA policy as it relates to transgender inmates, and with the Office of Administration on creating a written policy to protect LGBTQ employees. So thank you very much for allowing me to present this way. I am so sorry that I was not able to be there in person because of a schedule conflict with the governor's office. But I'm really pleased to be able to produce this tape and to present this to you. I do want to mention I just had my birthday. This was a very important birthday. This was the 30th anniversary of my 29th birthday. And what I want for my birthday is for more Twitter followers. So I believe I have 1,150 Twitter followers, and I'm looking for as many as I can get. And so this is my Twitter handle, @PhysGenLevine. Thank you very much.
That was an absolutely fantastic talk, so can we get another round of applause, even though she's not here to enjoy it? So I'm going to call her office right now, and we'll get her on the line. So the way this will work is because it'll be connected to my phone. Anyone who has a question, raise your hand. I'll call on you. Ask your question, then I'll repeat your question to Dr. Levine. And before I call her, Dr. Chanel wanted me to remind you all that there is a curriculum renewal town hall meeting tonight at 5 o'clock from 5 to 6:30 in this room. Food will be provided. I know you all have a lot of emotions about our curriculum, so come here and have your voice heard. And just stand by while I phone her office. Good, how are you? No problem. We just finished up your talk, and I'm about to plug you into our speaker system so you can speak to our student body for the Q&A session. Wonderful. Hello?
Yes.
Hi, Dr. Levine. So you're now plugged into our system. Guys, can we get one more round of applause for Dr. Levine's talk? And does anyone have any questions for her? Okay, well, I actually do have one question.
Sure.
What advice do you have for us as future physicians that we can take away from your talk to make sure we never marginalize anyone in our own practices?
That's a very good question. I think that one of the most important lessons to learn is not to make any assumptions about individuals. And I think that that's true in general, but particularly true for sexual and gender minorities. So I think that when we make assumptions about people, we display sort of a lack of cultural competency, and then we're more likely to miss the mark in terms of treating our patients. So I think it's very important to have a healthy respect for all of our patients and a healthy curiosity about them as individuals, and to avoid assumptions about them, and then just ask. And so if you don't know someone's sexual orientation, you ask. If you don't know someone's, there's a question about their gender identity or expression, you just, in a very polite way, ask. And so I think that that's one of the take-home messages for the student body.
Thank you. Anyone have any questions?
We do have a question submitted online from CMSRU.
Yep.
Dr. Levine, how would you advise physicians on how to make transgender patients feel more comfortable?
So you're going to have to repeat the question because I can't really hear.
So could you repeat that again? Sorry.
No, I think if you could repeat it to me.
Oh yeah, I'm sorry.
Dr. Levine, one of our online participants wanted to know how you would advise doctors to make transgender patients feel more comfortable.
Well, I think that it's important for LGBT patients in general to know that the medical office is open and is welcoming to LGBT patients. One thing that you can do, which is really kind of a signal to the LGBT population, is if you put a small rainbow flag, at the nurse's station, or like a little sticker or something, that can go a long way. Sometimes people put a full a thing that we welcome everyone to our practice, and including all and go through all different aspects of diversity, including LGBT or LGBTQ individuals. So a lot of it ends up being word of mouth, is that LGBT individuals, will realize that a practice is very open and welcoming, and so it'll be word of mouth. But I think that the more that the practice can, somehow signal that, the better. And of course, it's important for everyone in the office and the practice to be open and welcoming, and to be culturally competent for everyone, including sexual and gender minorities. So that includes, of course, people at the front desk and the medical assistants and the nursing staff, etc. So particularly for transgender individuals, it's important to work out policies and procedures for names and for gender. Of course, someone might be coming and the name that they use is not their birth name. It takes a certain amount of time to change your name. The name, that the gender they might use is not their birth gender. And I realize that for medical records, especially computerized medical records, that it might need to be in the system as John Smith. But if they're known as Jane Smith, it'd be important to have a subtext into the system so the medical assistant knows that, the person at the front desk knows that. People get the names and the pronouns right.
Okay, and that was actually a follow-up question they had, which was specific recommendations for working with pronouns.
Working with
Pronouns.
Yes. So, I think that you just asked, what name would you like me to use, and what pronoun would you like us to use in the office? For example, some people might present at the desk and want to use their birth name and pronoun, but then when they're in the office seeing you, would want to use their chosen name and pronouns consistent with their gender identity. So I think I would just be open to how individual patients want to be named and called. Now, if they haven't changed their legal name, then their name in the system, their name and pronoun in the system might, be different. And that's the way it has to be, for instance, to bill successfully on insurance. But then there's always a way to subtext it in so that people can be called consistent with their chosen name and pronoun when they arrive at the office. But you might also have to explain that, we're pleased to, your birth name is John Smith. We're pleased to call you Jane and use a female pronoun, but when the bill goes in, it's still going to say John Smith, because if you don't do that, the insurance won't pay for it. So, if you just explain that to people, they will understand and just be open and again, welcoming.
Thank you.
Sure.
So one of the things in the talk was that you said that for people who are in adequately supportive environments, they can start hormone therapy as adolescents. And I'm curious about how to approach that if they're not in an adequately supportive environment, whether their family doesn't support their gender identity or their community is hostile to it.
So again, someone will have to repeat that to me close to the microphone because I can't hear.
No problem. So he said that you had mentioned in your presentation that transgender adolescents coming from supportive households can begin hormone therapy during their adolescent years. But what is the protocol in place for those who don't come from supportive backgrounds?
Right. So, yes, the guidelines that I mentioned, which were developed in the Netherlands, but really widely accepted, supported by the World Professional Association for Transgender Health and accepted by, the American Academy of Pediatrics and all relevant organizations, do require that you have parental consent. Now, of course, that's great if you're in, the cornfields of Hershey, where I used to practice, where the parents would come in, etc. If you are at the Mazzoni Center, which is for instance, the LGBT Health Center in downtown Philadelphia, or the Fenway Clinic in downtown Boston, you might be dealing with street youth that have been thrown out by their parents because of their sexual gender minority. And then, of course, you're not going to have parental consent, as they'll meet criteria for emancipated minors. If you have a youth that the parents do not agree, and sometimes you might have divorced parents and they don't agree, you really cannot treat the young person until they're 18. So they'd have to be able to be an age of consent. So if you have someone brings a young person who's 16 and they're fine with an evaluation, but the parents don't consent to treatment, then you really can't treat the young person with medication the parents don't support until they're 18.
Thank you.
What can be done to sort of mitigate the harm of experiencing, as you put it, the wrong puberty?
His follow-up question was, what can then be done to mitigate the traumatizing experience of going through the wrong puberty?
Well, counseling and therapy primarily. So if you have, a transgender teen who can't get either blockers or start hormone therapy, then it's important to have supportive counseling and therapy to help them. For a transgender young man, female to male, then you could probably give certain hormonal treatment to prevent periods. You could use Depo-Provera, you could use continuous oral contraceptives to prevent periods. But that's probably the best you're going to do. I mean, you can negotiate with the parents. Maybe they would allow a transgender young woman to get spironolactone, even if they can't get the androgen blocker, even if they won't allow estrogen. So, you would try to negotiate. And you would try to work with the family to understand the significance. I've had parents who, when I've seen them in clinic, at first said no, but as time went by, they saw a therapist, the young person was in therapy, the family was in therapy, they continued to see me. Over time, then they agreed, for hormone therapy. So you don't give up. You just need to continue to see them. And it's important to have enough to have a healthy understanding of where the parents are, where the family is, with a transgender teen or adult. It seems like a loss. It seems like almost a death. And that, to the transgender person, that doesn't make any sense because they're still there. But they're grieving the expectations that they had for their quote-unquote son or their daughter. And you have to let parents and families go through that grieving process, as hard as it is. And as you know, grieving anything follows certain stages and takes time. And then usually, as they're going through that process with continued support, they will come around.
Thank you. Tara, you have a question? Dr. Levine?
Yes.
The question was, is there any overlap between the work you're doing and the prevalence of eating disorders, particularly among LGBTQ individuals?
So that's a very interesting question. So I've actually given several talks about eating disorders in LGBT individuals and in particular eating disorders in transgender individuals. So the LGBT population and transgender individuals in particular do have an increased incidence of eating disorders. Transgender women, so male to female, youth and adults can sometimes have eating disorders to try to lose weight to have a certain female appearance. So they can have restricting eating disorders, sometimes lead to binging and purging. So that's been reported, and I have seen patients in my office. In addition, female to male individuals can eat in certain ways, high protein or even take substances to try to bulk up their body more. And I have seen that as well. Also, one way to not have female pubertal symptoms is to be somewhat anorectic and to lose weight, and then you don't have breasts and periods. So I have seen all of that. And you need to treat the eating disorder, and then you need to address their gender identity and expression. I just actually had a phone consult about that last week, is that we would use in a transgender young man testosterone as an incentive for them to eat and to gain enough weight that they have, for instance, muscle mass that you could use an intramuscular injection in. But that young man was not eating to avoid having breasts and periods. So we do see eating disorders in the transgender population. We also see eating disorders in the greater LGBT population. Gay men have a higher instance of having eating problems in order to be particularly buff and fit. And lesbian women and bisexual women sometimes have problems with binging and obesity. So we certainly do see eating disorders in the LGBT population.
So Dr. Levine,
Yes.
the question was, if a teenager chooses to start an anti-puberty regimen but is unsure if they want to be a parent in the future, how long does it take, or have there been studies done that indicate how long it takes for the anti-puberty regimen to interfere with the person's ability to reproduce?
So, reproductive options is a critical issue for the, transgender youth and transgender individuals in particular. So, so it depends what age you're talking about. So if you're talking about a teen that has gone through puberty but is now going to have cross-gender hormone therapy, for transgender women, young women, you can bank sperm. And that's, not that hard to do. You'd like to do it before the spironolactone and the estrogen are very soon after. And you can bank sperm, and it's not that hard to do, and it's not that, it's expensive, but it's not that expensive. For transgender young men, female to male, that's an issue. You can bank eggs, and you can bank, of course, fertilized ovum, but that's not cheap and easy. It involves laparoscopy, taking pro-reproductive hormones, and then the expense of doing the banking of the eggs or the fertilized ovum with in vitro. And so that's quite expensive, and insurance won't pay for it. It is theoretically possible for a transgender man to stop hormones after 5, 10, or more years and then have a baby. There was a gentleman, transgender man on Oprah that did that. He wasn't the first person to do it. He was just the first person to do it and go on Oprah. And he's had several children that way. But you can't assume that. It's not particularly healthy for eggs, ovaries and eggs to get testosterone for 5 or 10 or more years. It's sort of like a mega polycystic ovary syndrome. And of course, we know individuals with PCOS can have problems with fertility, but it can be done. So that's a quandary. Now, with the youth that we give the blockers for, so if for the youth, the peripubertal youth, that we start blockers at pubertal stage 2, and then we bring them through the system, reproductive options can be limited because we're really not letting them go through their birth puberty, and then we're giving the cross-gender hormones. So at the moment, they are sacrificing their genetic potential. So the question, that's why I co-authored an article about that where we sort of investigated it, but there's no magic answer for that. So that there are, if you start pubertal blockers and then you right at 14 to 16, you put them through cross-gender hormone therapy, they never do reach reproductive potential, and so they are losing their reproductive potential at this time.
Thank you. We have time for one more question.
Sure.
Eamon.
I think it's really obvious that the vast majority of LGBTQ undergo some kind of emotional abuse from their families and communities, and even in a lot of cases, physical abuse. So what are some things we can do as healthcare professionals or these physicians to help change that culture that's usually almost time in the youth?
So Dr. Levine?
Yes.
Yep, the question was, so many LGBTQ teenagers undergo emotional or physical abuse as a result of being LGBTQ from their families, and what can we as practitioners do to work to change that culture and maybe even intervene?
Well, certainly, if you're seeing a family and you feel that the child or the teenager is suffering overt physical or emotional abuse, that would be a referral to Children and Youth Services, right? So if you feel that a child is being abused, then you are morally and legally required to call Children and Youth Services to address that family's needs. But in general, I think that it's important for pediatricians and adolescent physicians and family physicians to work with families on accepting their children the way they are. And not to have, not to, of course, they might go through a grieving process, but not to harass or oppress or victimize their kids. Certainly not to throw them out, etc. So I think it'd be really incumbent upon primary care physicians to work with families who have LGBTQ youth on accepting their child and exactly the way they are. I also think it's important for physicians to advocate in greater society. So, through whether it's through organized medicine, the AMA is supportive of LGBT individuals. I know PA Med is supportive of LGBT individuals. And of course, there's GLAMA, the Gay and Lesbian Medical Association, etc., to work within your specific specialty society. So if that's family medicine or peds or internal medicine, etc., and then to work, in the community for more to create a welcoming and actually celebratory environment for diversity in all of its aspects, including for LGBTQ people. So whether that's in your local community or in your state or federally, to advocate for diversity, which I think strengthens all of us, whether it's in a school, in a community, or in a state, or in our country.
Thank you.
Thank you.
We do have one more question from our friends at
Sure,
Cooper.
I'm fine.
So, Dr. Levine, you mentioned the statistic of 50% of men who have sex with men of color have HIV. Why do you believe that is?
Well, that's a very interesting question. So it's startling. 50% of African American men who have sex with men have a lifetime prevalence of HIV. I think it has to do that we really, in terms of public health, have not really developed and crafted the right message to hit the African American community, gay and bisexual, and in general African American community. So we have done a very good job in some other communities in terms of safe sex guidelines and HIV prevention, but in terms of that community, we don't seem to be hitting the mark in terms of how we reach them, in terms of our cultural competency, etc. So I think that in public health, so that's in communities. In cities such as Philadelphia and Pittsburgh and other cities in Pennsylvania, I'm sure your cities in New Jersey, from a statewide point of view and from a federal point of view for Health and Human Services and the CDC, I think we have to engage the community itself about how we best to craft our message of HIV prevention and PrEP, pre-exposure prophylaxis, post-exposure prophylaxis, and safe sex guidelines to best reach those individuals in the community. I think that sometimes we think we know what the right message is, and then we distribute it, and it's not the right message for them. It's not crafted in the correct way. So I think that's a challenge for public health in general and for the medical community to be able to do a better job to access and teach individuals in that community how to protect themselves, and to have much better access to PrEP and post-exposure prophylaxis.
Thank you so much, Dr. Levine.
Thank you.
Thank you.
So again, I am so sorry that I couldn't be there in person. The governor is signing several bills for opioid overdose prevention, which I've been working on very diligently. I had to be here, and when the governor calls, and if you're in the cabinet, you have to reply. So I'm sorry I couldn't be there in person. I hope that the taped remarks went well, and I'm very pleased to have been able to at least call in to answer your question.
Thank you so much for doing this. Can we get one
All
more
right,
round
you
of
take
applause?
care. Thank you.
Thank you all for coming out today. This concludes today's talk, and just a reminder, tonight, 5 o'clock, curriculum town hall meeting. All right, see you.